Nisaj, can you tell me what you're seeing on the screen here?
Yeah.
Yeah. What is that? It represents something.
So
Particularly
the tibial Plateau and the attached is depicted in different colors.
Is it tibial plateau?
Yeah. Yes, sir. Tibial Plateau.
You don't call that particular thing tibial plateau, something else. Attachment of various structures.
Yes, yes. Attachment of various structures are depicted in with different colors.
Yeah, from front to back, isn't it? Or back to front. Yeah. What all are attached? What all are the things that you see there? Can you tell them in order?
If you're going from anterior aspect, the most anterior is the anterior horn of medial meniscus.
The most anterior is?
The most anterior is the anterior horn of medial meniscus.
Oh, okay.
Then attachment of ACL.
Okay.
Then attachment of anterior horn of lateral meniscus.
Okay.
Then comes lateral meniscus. Meniscus. Finally, most posterior is the posterior cruciate ligament.
I didn't get the last three. Lateral meniscus, you said.
Posterior
Front to back, this is medial meniscus anterior, anterior cruciate ligament. You said this is anterior attachment of lateral meniscus, and then this, what is this?
Posterior horn of lateral meniscus, posterior attachment of lateral meniscus. Posterior root attachment of lateral meniscus, and the next is posterior root attachment of medial meniscus, and finally PCL, posterior cruciate ligament.
So this is PCL, right?
Yes, sir. Yes.
Do you have any mnemonic that you can remember this with?
Yes, sir. It's like Medical College, Lucknow Medical College.
Okay. Okay. Good. So so that's a better representation there. You can see the medial meniscus anterior part, then the anterior cruciate, then under the anterior cruciate you see the lateral meniscus anterior horn, and then immediately posterior horn, which means the lateral meniscus is almost circular, isn't it?
Yes.
That is one thing to remember. The lateral meniscus is almost circular, so that the anterior and posterior attachment of the meniscus is adjacent, so that it becomes a circle like that. So that is one thing to remember. So without the mnemonic, it is probably difficult. This is how I remember. The posterior most is easy to remember. The posterior most is PCL. And then the middle two are lateral meniscus. Okay. So you can answer this one as well. What are you seeing here?
It's like an avulsion fracture, probably.
Can you just start with this is an X-ray of, in exam it is
There is a plain radiograph of a skeletally immature child, lateral view of knee joint, showing the proximal tibia, fibula, and the distal femur, and which shows the fracture of tibial plateau, the anterior aspect of the tibial plateau, probably due to with avulsion of ACL, anterior cruciate ligament.
Okay. Again, you're saying that this is tibial plateau. This is not exactly tibial plateau, is it?
Epiphysis.
It is the physis, but it is still something else. I'm looking for a particular word. Okay, it is an avulsion fracture. Okay. So this is the, from front to back, this is the what attached. What is attached to this fragment?
So, a meniscus root and anterior cruciate ligament, ACL.
Okay, this is an anterior cruciate ligament avulsion, isn't it?
Yeah.
So you should see the meniscus in front of that.
Yes.
Or if it has not avulsed, because this piece has avulsed, you should see the meniscus sitting under this fragment, correct?
Yes, yes.
Okay. So what do you do for this fracture? It is a child, so.
So in this case, it is completely ours. So we need to fix the fracture with screws, probably sir, with cannulated screws. Sorry, cancellous screws.
Okay, cannulated. It can be cannulated cancellous screws. Yeah. From where will you approach that? How can you approach? From where to? From top to bottom? From bottom to top? Where do you approach? Where do you put the screw?
So from top to bottom, screws will be from top to bottom.
From here to here, like this.
Yes.
It'll be very difficult to approach from inside the femur, isn't it?
Yeah, sir, not from inside the femur. Can do through the joint.
Okay. Okay, I'll show you another picture. Okay, this is the arthroscopic view of the fracture. Do you understand what you're seeing here? This is the avulsed piece which has lifted off from the tibial spine. This is the, this would be the, this is the femur, this is the tibia, this is the avulsed fragment. You can see blood from inside the fracture. This is what?
Yes.
Yeah. So that is the anterior horn of the meniscus is under the fragment here. This is the fragment. Understand? Yeah?
Yes, yes, yes.
So if you try to just put some screws from top and press this fragment, you will have the meniscus stuck inside and it will go on to further problems. Okay? You have to lift this meniscus out and then fix this fragment. Okay? Okay, so that is the fixation. Someone has done a fixation. It is not my case, obviously. Can you tell me about, is there anyone else, senior exam going PGs? Any volunteers?
Yes, sir.
Who is this?
So this is Dr. Gautam.
Dr. Gautam, hi. Can you comment about this fixation? What is being used?
So it's a partial threaded cancellous screw, two partially threaded cancellous screw that has been used, and it's intra-articular.
Where do you think they approached this from? How did they insert it there?
So maybe they have gone through the open approach, open parapatellar.
Very much possible, isn't it? Very much possible that they have gone through the open approach. They might have done a medial parapatellar approach and expose the fracture fragment and then put this. What else can you say about the fixation? Is it a good fixation?
So the fracture is reduced, but the screws is not well inside. I mean, if they wanted to have used, they could have gone for the headless screws. But this is not a. We should have gone from the below up rather than up to down, because this is an intra-articular. It's a growing child. Or we can use the threads itself. We just pull down the fragment and then we could have tied from outside.
Yes, well, tying from outside is a different method altogether, isn't it?
Yes.
Fixation with cancellous screw is different, and tying from outside is a totally different technique. I want you to comment on this thing. Do you think the fixation is okay here? Has he violated any basic principles at all?
No, so he has gone through the physis.
Yes. What has he not gone through?
I think the fragment is, he didn't get hold completely because two screws are there, but I think both have missed the fragment.
I think he has gone through the fragment. It is a big fragment, and I think he has gone through the fragment. And I think both screws probably have gone through the fragment. What has he not gone through? I think he has taken extra care to not go through something here, to protect something.
The physial.
The physial plate, isn't it? I think he has taken extra care not to go through the physial plate. Yeah?
Yes, sir.
Which would damage or maybe affect the growth later. It is not like putting a smooth caver through the physial plate to put two big cancellous screws there. So you can expect the physial plate to be damaged at least a little bit if you cross the physial plate there. So he has taken extra care not to cross it. I think at least the X-ray number C is probably after union even. You cannot see the fracture line. Probably it has healed. Okay. Any other principle that he may have violated? I think. What about the fracture line and perpendicularity to the fracture line and stuff like that?
So one screw is perpendicular to the fracture, but the second screw is not, and it's diverging rather than converging. If he has two screws, he could have got for parallel.
It is very difficult to get these two screws inside. You know, two screws itself is very difficult here. Parallel is going to be very, very difficult. You know, the only access you have is like this, so you cannot be always perpendicular to the fracture line, fracture line here, and certainly very difficult to go against the pull of the ACL here. So I think this is a good, well-reduced fracture. Probably will have good results later. Okay. Right. So what are you seeing here now?
So this is the X-ray of the knee of a skeletally mature patient in AP and lateral view, and we can see a avulsion fracture, bony avulsion fracture of the PCL or tibial spine.
On the AP view,
so it looks like a tibial spine. In the lateral view, it looks like a PCL.
Okay, so just to be clear, for the previous person as well, for Dr. Nisaj as well, these fractures are not tibial plateau fractures. Okay, you cannot say that this is tibial plateau. This is the tibial spine. So the attachments of 6 structures on the tibial spine is what we were talking about initially.
Yes.
Not the tibial plateau. This cannot be confused with tibial plateau. Tibial plateau, you have other classifications and things like that. So there is medial, lateral, all those classifications there. Okay, Schatzker classification is there. So this is because you have the lateral view as well here. You can see that it is a
PCL avulsion fracture.
PCL avulsion fracture. So from the picture that we showed earlier, this is the posterior most attachment there. Again, another avulsion. So what is the treatment for this?
So this is the avulsion fracture which minimal displacement. So we have 2 choices, either conservative or surgical. We can give him a PCL brace and mobilize, or if you want for the surgical, then we have arthroscopic technique or open technique.
Okay. What approach will you do for open technique?
So for the open technique, we can use the modified bulks approach.
What is that?
So we put the patient prone, and we go between the heads of the gastrocnemius. We can put the inverted L incision.
Okay. L or S? Okay. And what are the structures very close by that you should be worried about?
So popliteal vessels and popliteal nerve.
Yeah, the neurovascular bundle is very close, isn't it? So close reduction and fixation is probably not the best idea. Yeah. Although some people do suggest that. So I would do an open reduction, fix the fracture, and put. How do you fix this fracture?
So we can use either 1 or 2 partially threaded screws with the washer. If we can get depending on the size of the fragment. Here it looks like around 2 centimeters, so we can get 2 screws, 4.5 partially third.
Yeah. Yeah. Okay, so that is one way. The arthroscopic method is also there, where you drill tunnels,
and pull the fragment and put it with the fiber tape.
Okay.
With the help.
Okay. So anyone else now? Can anyone else volunteer, or else you can continue with the. Anyone else? Nobody? Gautam, I think you have to come back. Or?
Sir, this is the X-ray of the knee in the AP view showing a Wilson fracture from the tibial spine. Segond fracture is the name of this fracture.
Okay, what does it signify?
Sir, LCL avulsion from the tibial.
From the tibial?
ACL avulsion, anterior cruciate ligament.
ACL avulsion?
ACL, it will be LCL, sir. ACL will be.
Is this a standard AP view?
No, it's a notch view.
Ah. Why has someone taken a notch view rather than AP view? Okay, anyway, anyone else wants to have a go at this? Okay, Gautam, I'm going to quiz you again. You said collateral ligament avulsion, yeah?
Yes.
Where is the collateral ligament attached on the lateral side?
Oh, sorry, sir. It is in the fibular head. Sorry, I was wrong.
Okay, so where has this small piece? Is it a fracture?
This is avulsion.
It is an avulsion. From where?
From the proximal tibia lateral side.
So what is there? Okay, someone else.
Meniscotibial ligament.
Anyone else?
Meniscotibial ligament. Sorry, sir.
No. Who's the next exam going person?
Sir, lateral capsule, sir.
Who is this?
Sir, Karthik. Sir.
Karthik. Okay, Dr. Karthik. This is the Karthik Siddhartha. Yeah?
Yes, sir. Yes, sir.
Yeah. This is capsule. I don't think it is capsule either.
Yes, sir.
Okay. Yeah. What does it signify? What are you worried about now?
Sir, that it is most often associated with ACL injury, sir.
Okay. Anything else? Any other injury you have to suspect? ACL is the number one thing here, but when you see this, you think of more serious injuries inside the knee. Yeah? Could
PLC,
be ACL. PLC could be as well.
Yes, sir.
What is the mechanism of this injury?
Varus stress, sir.
No, you were correct the first time around.
Sorry, sir. Hello?
You were correct the first time around. Sorry, varus injury. Yeah, varus. Varus and?
Sorry, sir. Hello?
Varus force and what else? It is not
Varus and rotation, sir. Any external rotation?
Rotational forces as well. Yeah. So it is supposedly it will not happen without intra-articular ligaments giving way, especially the ACL. Okay. So if you force the knee into varus and internal rotation in a slightly flexed position, first the ACL gives way and then this structure gives way. Yeah.
Yes, sir.
So you have to suspect more serious injury which is not readily visible on X-ray.
Yes, sir.
Like the ACL. Anything else that might be injured? PLC you said, which is correct, yeah. And the meniscus is also possible to be injured here. Okay.
Yes.
PCL also is possible, but these are the most common things. Yeah.
Yes, sir.
So what will you do? You see this in a casualty, you go to the casualty and you see this X-ray, the casualty register is saying some small avulsion fracture is there. Can I send him in a plaster? And what is going to be your approach?
We'll give an initially rigid knee brace for 4 to 5 days till the hematoma, everything is resolved. So after 5 days, we'll take an MRI to confirm what all the structures are injured and go for repairs.
Depending on what the MRI shows. So more investigation is mandated here, isn't it?
Yes, sir.
Yeah. Oh, do you have to wait for 5 days?
Yes, sir. There might be artifacts like we cannot initial 4-5 days for the hematoma to get absorbed to get a clear picture.
I don't think we have to wait for 5 days for anything to show up. Okay, hematoma doesn't get absorbed completely anyway. Okay, so tell me about the ACL then. Where is the ACL attached? From where to where does it run?
Anteromedial to posterolateral, sir. Anteromedial in the tibial plateau and posterolateral that is the medial surface of lateral femoral condyle, sir.
Okay. How many bundles? What are the different bundles of ACL?
Anteromedial and posterolateral bundle, sir.
Okay. How is it named? Why is it called anteromedial and why is it called posterolateral? Anterior where? Posterior where? Lateral where? Medial where?
I'm not sure.
Okay. Does anyone know? So that is the ACL there. You can see the two bundles, yeah? Anterior on the tibia to the medial side of the lateral condyle runs the anteromedial bundle. Posterolateral is posterior on the tibia to more lateral on the femur. Can you see that?
Yeah.
Agreed? What about the PCL? How many bundles does that have? How many bundles does the PCL have?
The anterolateral and posteromedial bundles.
Yeah, so slightly different, isn't it?
Yes, sir.
So there you go. That is the PCL. Can you see the post?
Yes, sir.
Right. Anyone else who want to answer questions now? Who is the next senior person? Hello? Anyone?
So, can I answer?
Yeah. What's your name? Sorry.
Oh, so Gautam here again.
Gautam again. Okay. Right. What are we seeing here?
So this is a MRI in the trials view showing the double PCL sign.
Okay. What does that signify?
So this is a flipped meniscus with a most probably bucket handle tear.
No, again. So we were talking about double PCL sign. What does it signify?
So it's a flipped meniscus, most probably due to a bucket handle tear.
Okay, okay. Bucket handle tear of which meniscus?
The medial meniscus most of the time, nearly.
Okay. Can you get a double PCL sign with the lateral meniscus? Have you seen one?
No, sir.
Why? Should be possible, right?
Yeah, it should be possible.
Eh?
I don't
Do you
know.
think it is possible?
It's difficult because the meniscus has to flip and go further behind.
Further?
It is difficult to go, but theoretically possible. I don't know. Practically, I have not seen it, so I can't say.
I think it might be technically impossible for the lateral meniscus to come. This is slightly on the medial side of ACL, isn't it?
Yes.
Isn't it? So as long as the ACL is there,
That so it can't cross. But
the lateral meniscus cannot come to this side. Yeah.
yes,
Unless the ACL is also gone, and then the bucket handle of the lateral meniscus can theoretically come on this side. I suppose it is possible, but almost always you see a double PCL sign when it is the medial meniscus bucket handle tear, isn't it?
yes.
Okay. And apparently, if the ACL is gone, the medial meniscus bucket handle can go further laterally, and you don't get the double PCL sign. Okay.
Okay.
Some photographs. Can you tell me who this is? Anyone? The name came across just a few minutes ago. Gautam, any exam going PGs? It is not an easy question, but this is Segond. Okay. Does anyone know what his specialty was? Okay, he was a gynecologist mostly, but also specialized in knee injuries. Long time ago. So he described this thing in 1870s, Segond. Okay. Gynecology plus knee injury is a good combination, isn't it? Who is this guy? Very famous personality you might have seen. Can anyone answer this? Nobel Prize winner. Any guesses? I'm sure you have seen the picture somewhere. Anyone in the group? Wild guess?
H.O. Thomas.
Anything orthopedics is H.O. Thomas, isn't it? Okay, no. He's not particularly an orthopedic person. This is Röntgen.
Oh,
Wilhelm Conrad Röntgen. Okay, why am I asking this? When did he invent, what did he do?
hand of Martha. That is the X-ray of his wife. And
When did he invent or chance upon X-rays? Approximate time.
1890s.
1895, yeah, turn of the century. He got his first Nobel Prize in Physics in 1901 for this, yeah. So 1895, and the reason why I'm asking is, you know, the other guy, Paul Segond, he described Segond's fracture in 1877 or something. So before X-ray was invented. Can you tell me any other major fractures which were invented or described before X-rays were invented? Any named?
Chopard.
Sorry?
Chopard? No.
Sorry, say that again.
Chopard? No.
Chopard. I don't know about Chopard fracture, but
no, no, sorry, sir. It's this.
Upper limb, 3 main named fractures.
Boxers,
Yeah.
Colles.
Colles,
Yeah, Colles,
Gallias.
Montegia, Galeazzi fracture, all were described many years, many decades before X-ray was invented. Yeah, 1850s and all. So these guys must have been extraordinarily brilliant, isn't it, to describe a fracture without even having the advantage of X-rays. Colles described all the 6 deformities of Colles fracture without X-rays. Doing it on, I don't know, cadavers maybe. Paul Segond described the fracture by doing biomechanical studies on the knees and twisting the knee in particular fashion. He found out that the ACL breaks, and then this avulsion fracture, which is named after him. Okay, so pretty remarkable to find out that such forces cause such a fracture even without X-rays were around. Right, who is next? Anyone else? Any exam going person want to have a go? Karthik? I'm picking on the guys who already came forward.
Sir.
What are we seeing here? Anything peculiar? Describe what you're seeing anyway.
Sir, it is. So I don't see any pathology.
Sorry?
So is there any? It is a X-ray, plain X-ray knee, distal femur and proximal tibia.
AP lateral. Plain X-ray AP view of, isn't it?
Okay.
Hello, I can't hear you now.
So is it osteochondritis, sir, of distal of the femoral condyle, sir?
Of the femoral condyle. Which femoral condyle? Medial or lateral?
Lateral, sir.
Lateral femoral condyle. Anyone else has any other opinion? Okay, senior guys, Gautam?
Yes, sir.
Any other opinion on this?
So the orientation of the femur with respect to tibia is not looking right. I don't know whether it's an inverted image of the femur or
Inverted image of the femur. I'm not sure what you're
sorry.
thinking at. Who else is there? Senior person out of 20?
Fairbanks sense.
Huh?
Post meniscectomy, you get the Fairbanks changes in the femur, sir. Is it?
No. I don't think it has anything to do with meniscus.
Is a patella translated slightly lateral?
It's very difficult to comment about the patella position because you don't know the rotation of the leg. But I don't think it is anything to do with the patella.
Like mild opening is it compared to lateral?
Sorry?
Mild opening the medial joint line. I mean medial side.
No, I don't think.
Is it a subluxation? Because the
Who is this?
Gautam again, sir.
Gautam again, yeah. I don't think it is subluxation. I can understand why you are saying this because the lateral tibial plateau appears to be a bit overhanging.
Sir, there was an option from the chat. Dr. Abhina has said, could it be a discoid meniscus?
Discoid meniscus. Okay. Who was this?
Dr.
Sir, my name is Dr. Ijaz.
Dr. Ijaz.
Yes, sir.
Okay. Why do you think this is a discoid meniscus?
The lateral meniscus appears a bit flattened.
Lateral meniscus appears flattened.
No, I said lateral tibial plateau.
Lateral tibial plateau appears flattened here. If anything, it appears a bit like the medial. Well, you have read something about discoid meniscus, about flattening and something, isn't it?
Yes, sir.
What is that? What gets flattened in a discoid meniscus?
The medial tibial plateau.
Medial tibial plateau. Discoid meniscus.
It's medial femoral condyles.
Medial femoral condyle. Where do you get discoid meniscus usually? Lateral. So how do you get flattening of medial femoral condyle in a... Sorry?
Flattening of lateral femoral condyles.
Yes, mild flattening of a lateral femoral condyle can be occasionally seen in discoid meniscus. Yes, and a consequent increase in lateral joint space, probably. Yeah, these are the X-ray findings of a discoid meniscus. Very non-specific findings, but once you see a discoid meniscus in MRI, back and look at the X-ray, you may appreciate these features. Do you think that is what is happening? Is there any flattening of the lateral femoral condyle here?
Yes.
It is not flattening. The joint line appears normal, as in the curve appears normal. There is something else abnormal about the joint line there. No? Can anyone appreciate two joint lines on the lateral side? Two lateral joint lines on the medial femoral condyle. Lateral femoral condyle. No one can appreciate that. Is that because of the computer picture? There is one line here, and there is another line here. Can anyone appreciate that?
Yes, sir.
Yes, sir. Yes, sir.
What is that? Is that patella?
Hypoplastic.
Hypoplastic. What?
Lateral femoral condyle, sir.
No, I don't think it is. I don't think hypoplastic lateral femoral condyle gives you double joint lines like that.
Inferior pole of patella, sir.
Sorry, say that again.
Inferior pole of patella, sir.
Inferior pole of patella, yeah, you can get confused like that, but the shape of the inferior pole of patella is not particularly a smooth curve like that, is it? It's more triangular and it doesn't look like a double joint line. Okay, all the 20 PTs here, DNB students here, has anyone seen anything, or can anyone say what this might be? This is not an rare thing to see. You might be called into casualty with a knee injury, and this X-ray might come up, and you have to pick this. Okay, I'll move on to the next picture.
Hofa.
Everyone knows. Eh? So, I mean, to have two joint lines like that, you have to have two pieces there, okay, discontinuous pieces there. Yeah? So this is the Hofa fracture, which is slightly migrated up or down. Yeah. So you have to be aware of that thing. You should pick that there is something abnormal there, first of all, and then you should look for that. Once you see the double joint line, your suspicions should be very, very high for this kind of thing. Okay. And if you go back, there is something going on the lateral aspect here as well. Yeah. Something not quite right, at least. So you should ask for more imaging. Definitely you will see a lateral view anyway. This is why you should not take just one view, always take 2 views. Okay, so who's going to answer the questions regarding Hofa fracture? Gautam, how are you?
So, since this is an intra-articular fracture, so we have to fix the fragment. So open reduction internal.
To fix the fracture, is that all? You need rigid fixation, anatomical reduction.
Anatomical reduction and rigid fixation.
Yeah, you should say those things. Okay, it should be a habit when you say these things. At least for the exam, when you say, okay, this is an intra-articular fracture, therefore it needs fixation, is not the right way to go. You should say that this is an intra-articular fracture and therefore it requires anatomical reduction and rigid
internal fixation.
Yes. Okay. Just make it a habit to do that. Okay.
Okay.
Okay. So how will you approach this?
So we can go through the medial parapatellar approach here, because this is this deformity can be better seen when we see end-on view, because if many times if we go for a lateral approach, we may not be able to appreciate the reduction properly.
Very good. Well, that is what I would do. Okay. I'm sure there are other approaches, and but this is what I would do. Go through the front, open the knee up completely, like you do a knee replacement kind of incision, medial or lateral parapatellar, depending on medial or lateral Hofa. Yeah. Open everything up. And how do you see the fracture? What do you have to do to see the fracture? Gautam?
So we have
opening the knee and moving the patella away. You have to flex the knee, isn't it? Once
yes, 90-degree flexion, then we can see
the fracture, the anatomy of the fracture completely. Yeah. Then what do you do?
So we can, if it is not extending to the shaft, then we can use screws to fix it. If it is associated with the fracture line is going in the shaft, then we have to use a plate to support it. And we can put screws through the plate or outside it. An interfragmentary screw we can put initially, and then we can support it with the plate.
Okay, this fracture is not going through the femur itself. It is just the condyle, isn't it? So how do you treat this fracture?
So we can reduce the fracture, keep it with the clamp, and then we can use 2 screws to fix it.
Okay, with the clamp, and then will you use anything else?
First we will fix it with the K wire, then look for the reduction.
Yeah, K wire is a very useful thing here, isn't it? Use a lot of K wires if you want. Okay, and then what will you do? You fix the fracture with a K wire, couple of with not just one K wire, many K wires, and see how the reduction is on both visual examination as well as
under the C-arm.
Under C-arm. So you have to be 100% convinced that it is fully reduced. Yeah. And then once you are convinced about that, then what will you do?
So we can use 4.5 cancellous screw or cortical screw.
Okay. Why cortical screw?
So we can bury the screw here, and most of the time we don't remove those screws, so we can use those also.
Cancellous screws also you can bury, isn't it? From where to where do you put? Where do you put these screws? Where do you start?
So from posterior to anterior. It's like.
Oh, you're talking about posterior anterior screws. Okay, okay, right. If you're putting a posterior to anterior screw, you might as well use something else, not a cortical screw. What else can you use?
Headless screws.
Yeah, you can think of headless screws nowadays, isn't it? Yes, you can bury the screw head, but better would be to go for headless screws, Herbert screws kind of thing. Is that the preferred method? Back to front? I don't think back to front is the preferred method here. There is a very convenient way of fixing it from the front to the back. You can put the screws through the non-articular aspect of the anterior femur, the edges of the articular surface, and catch the fragment, because you have used it, fixed it with wires, and probably holding it with some clamp. You can put cancellous, partially threaded cancellous screws, 4.5 if possible. Another useful one is the malleolar screw. You can use that as well. The small 4 mm cancellous screws nowadays that we have, I don't think the thread is big enough to give sufficient purchase, but that can also be used. I would use a washer as well, but go from the front, usually on the lateral ridge, articular ridge, and you don't particularly have to bury the head completely. You can use normal heads there. You don't have to use headless screws, and you use 1 or 2 screws to fix it. Okay. So you can see what I was talking about. Can you comment about the fixation? All good? Gautam?
Yes, sir. It's anatomically reduced. But still there is a step in the AP view.
Yeah, I don't think it is 100% anatomically reduced. You can see a step at this site as well. Maybe there is some comminution, and maybe the reduction was not perfect. Maybe some tilt is there. The double joint line is still visible there, so I would be a bit worried about this. Okay, this is not my case. It is, I've just picked it up from the internet. So yeah, I think I'll stop there. Is that time now?
Okay.
9 o'clock. Is there anything that you want to discuss? Any questions? Hello.
No, sir. No, sir.
Thank you, sir.
Thank you, sir.
Thank you. So is that it now?
Yeah, thank you, Dr. Bibu. That's fine. It's nice session.
Thank you. Dr. Jis?
Thank you, sir. Nice session.
Dr. Jis?
Yeah, I'm hearing you.
Oh, okay. Was that okay? Is that?
Yeah. It was pretty good, and I really like the way you build up right from the meniscal attachments to. That's the way it should be, and it is very well done. It was interesting as well. I hope everyone liked it.
Well, thank you very much. Thank you for the